Greetings, this is Gene Tyre welcoming you to another View from the Summit. Today our location is the Surgery Center of the Summit Healthplex, and we have with us visiting again Dr. Jack Powell III. Dr. Powell, since your initial surgery performed on cable television, I've had so many calls wanting to know when we're going to see another surgery. And each surgery that is performed here that we are privileged to televise and show to the community is indeed an educational experience for all. Dr. Cushing has done a shoulder surgery. Dr. Ballantyne has done a knee surgery along with your knee surgery, and the response has just been absolutely phenomenal. And I want you to know how fortunate this community is to have Georgia Bone and Joint located here. The community has given you great support through the years. When you came here, you were the only orthopedic, well, maybe a couple of orthopedic surgeons in Noonan, Coweta County, but you have seen your practice grow. And how many surgeons do you now have on staff at Georgia Bone and Joint?
We have 5 of them myself.
5 now?
5, 6 of us total. And we brought in, the latest one we brought in is Dr. Jason McNath. He's pediatric orthopedist that deals with children orthopedic problems, bone and joint problems, and we're really excited about having he and his wife and family here. He started in July. He's been a real addition. So what we've tried to start out with a general, and then I did 3 fellowships myself before I came back in certain areas just to have the expertise here. And then what we've done is try to bring more expertise in each individual we bring in. I like for them to have usually some type of fellowship when they come. And a fellowship is something that occurs, they do their 5 years of orthopedic residency, and we'll actually do a year of internship, then 4 years of orthopedics after medical school, and then they do another year of fellowship, or sometimes 2 years depending on what they do. But Dr. McNath did a pediatric fellowship at a fine institution in Memphis, Tennessee called Campbell Clinic. So we're real fortunate to have him in this community and really looking forward to working with him.
I know he wants to be very involved in taking care of children, and he has already received such a warm reception from our community, and being as I am up in Georgia Bone and Joint every day, I've seen more and more children come through Georgia Bone and Joint, and we're just so thrilled to have Dr. McMath on our staff. Dr. Powell, so many exciting things are happening at the Summit. We're experiencing great growth, and I know that the support that the community has given us is so encouraging, and we're very involved in the community. Football season is here, and we're getting ready to stand on the sidelines. We're going to do the bump and bruise clinics again on Saturday.
Yeah, the Bump and Bruise Clinic is something we started about 10 or 15 years ago, and we do we try to cover all the home games for the high school teams that we cover, and we're covering East Coweta, Northgate, Noonan High. Heritage School this year is going to have a football team for the first year, so we're looking forward to that. And also we do Sandy Creek over in Fayette County. So all the different orthopedists, and with the trainers sometimes, and the trainers are at some of the schools.
And I believe Russ Foley's involved in that with Georgia Rehab, and Russ and his staff do a great job.
They've done a wonderful, and Russ has been a real
of our students. Isn't he a professional in the?
He's been a real,
great for our community, for our students.
Absolutely, he's been wonderful.
Made so many significant contributions to this community. But today, let's focus.
One thing we do is we do have the Bump and Bruise Clinic after the Friday nights, and Bump and Bruise Clinic is a Saturday morning clinic where all the trainers come and the coaches come, so we actually can identify a problem that occurred Friday night and go ahead and get them started with icing or whatever care they need so they'll be ready for the next week. So we do that on Saturday mornings here at the clinic, and it's been very helpful to us, and it's been fun to work with the players and helps them return to play quicker.
So, Dr. Powell, the good thing is now people do not have to leave Noonan and go anyplace else to have their musculoskeletal needs met. All the orthopedic needs can be met right here.
Except for maybe when we diagnose a bone tumor here, of course that needs to be treated. There's a fellow at Emory Lane, Dr. David Munson, that does strictly orthopedic oncology. So anytime we have a malignant tumor of bone or something, or primary tumor, we usually do refer them to him.
Dr. Powell, share with us briefly, if you will, something about the surgery center and how important it is to be an outpatient center in the practice of orthopedic medicine.
Well, the surgery center has been a really helpful thing to us because it makes our life so much simpler, because we do strictly orthopedics at this center. It's called a single specialty surgery center. and Spingle's especially orthopedic center. So all we do is orthopedics. So the nurses are all trained in all the procedures we do, and things work so much more efficiently than doing all the other different type of procedures we do at the hospital. And we do a lot of inpatient, as far as total joints and spine surgery and a lot of major trauma at the hospital. But most elective things like arthroscopies, hand surgery, and things that you can send the patient on the same day are done here. And it's really helped us. We've had it for the last 5 or 6 years, and it's been wonderful.
Well, Dr. Powell, you're going to have the opportunity today to do surgery for us. We're going to view it, and it's a very common problem that people have. And I've had so many requests from our viewing audience for you to do this type of surgery. Is it carpal tunnel syndrome?
It's carpal tunnel syndrome, and we're going to be doing a carpal tunnel release. And it's I think it's probably, to me, it's one of the best procedures we have, because we rarely have complications with it, rarely have wound infections, and it usually works very well. And today we are going to be doing a carpal tunnel release. And I think you've got a little model there.
First of all, we'll talk about what you did after the surgery, but right now it's time for us to go to surgery.
Oh, good. We're ready. See you in the operating room. Hi, my name is Dr. Jack Powell III. Today we're going to be doing a carpal tunnel release. Carpal tunnel is a syndrome that I'll discuss later, but basically what we're doing is releasing a nerve where the ligament called the transverse carpal ligament puts pressure on the nerve, and it causes the hand to fall asleep. And this is usually from an overuse injury. We see it more commonly in diabetics and other entities. Today, these glasses I have on, which is these funny looking little loops, they're called loops. And what this does, it magnifies what I do when I'm operating about 3.5 times. So I have a field of vision about like this, magnified 3.5 times. I use this on most foot surgery and hand surgery, and also on spinal surgery. It really has helped. It helps you see things, and you can visualize exactly what you're doing. So the first thing I'm going to do is make an incision here. We've reduced our incision a good bit. We used to make a long incision. We made it much smaller. We just make it right at the palm here, and then we go through the skin. I'm getting ready to go through the soft tissues here in a minute with some scissors and pickups. I used to make an incision from here all the way to here, but there's a new technique out that's been out about 10 years called arthroscopic, where they're trying to release this ligament arthroscopically. But the problem is they were injuring nerves when they do it. So what that made me do is actually reduce my incision to this size, and therefore do all the surgery through a mini incision, which basically is just as good as the arthroscopic technique. I look at the arthroscopic technique, but I felt like I got a better release doing this. And if you look at the studies in 8 weeks to 3 months out, all patients are doing about the same. Occasionally the scar causes them a little pain here, but you've got to make an incision arthroscopically too when you do that. So I didn't feel like it was much of an improvement, and I feel like I can really do the surgery better and see the nerve much better when I do it open. So I'm going to go ahead and get started here and just go through the subcutaneous tissue and get down to the ligament. And when I get down to that, I will show you exactly what I'll be doing. What I'm going to do now is put a little retractor in here. It's called a Sin retractor, and it just sort of opens everything up for us. And we do these under local. We don't even put the patient to sleep. We just deaden the skin up here and the soft tissue so we can sort of see what we're doing. I'm just going to do some clean up work here to make sure everything's cleared up before we get started here. What I do is I work up under the skin here. I'm going to take my hand and come on up through here, the scissors, and just slide them all the way up here so we can really free this up. So I can work up under there, and I'll use another little retractor called a Sin retractor that'll hold it up. But this is a ligament that we're going to start releasing very shortly. Let's come right here a little bit better here. If you take a shot here, you can actually see can you come right down on this and sort of expose this? I'll try to. This is a ligament that I'm going to start releasing right now, and there's a little muscle called the abductor pollicis brevis that attaches over here. Can you see that okay there? And that little white band of fibers is the ligament, and the nerve sits right up under there. Let me have a knife with a scalpel. And that's what we're going to release. And take this like so there. That's what I want you to do. So the ligament I've released is right here. It's called the transverse carpal ligament. You can see this material right here. That's a ligament I released. And the nerve is sitting right up under. If you can take a shot, the nerve is sitting right here. Can you see that? And that's the median nerve, which supplies this finger, this finger, this finger. And what we do is we free that up so there won't be any pressure on the nerve, and that's what I've done. I'm looking for another little nerve called the little motor branch. It comes off the side here. There's a little branch called the motor branch, which I'm looking at right here. If you can show this, it sits right up in there, and it supplies this muscle, the abductor brevis, that brings your finger up. And you can see it's sort of running right up through here into the muscle, which it's a little scarred in. I'm just freeing it up a little bit better so we can see it well. It looks perfect. So what we've done is we've released this ligament here, and first of all, I released it up in this direction. Let's take it back this way a second. I released it in this direction, which you can, let's see, take that there. And you can see the ligament right here. There's a ligament. I mean, there's a ligament, and my hand is holding the ligament. Here's a nerve right here, and it's got there's 9 tendons that run under this nerve with this. And the nerve sits around those tendons. What happens is these tendons get inflammatory tissue on this whitish material. Is an inflammation of the tendons that run to our fingers that make them bend down. And the nerve sits right on top of that. So when the tendons get inflamed, then you have this ligament here. It puts pressure on the nerve, and that's what causes the carpal tunnel. So what I've done today is I've released this ligament, and so the nerve will have room to breathe, and that should take care of a problem. You can see how much freer this is than it was. And I looked at the little motor branch coming under here. It's hard for y'all to see, but it's sitting right, I was looking at it a minute ago, it sits right up under there going to this muscle there, and it's totally intact. And that's about it. And what we'll do is we'll just put some sutures in this, and then we'll be through. And of course we have a tourniquet, so that's why you don't see any blood here, because the tourniquet's here, and it just makes it. Let's come this way. This is called a simple suture here. I'm just putting one turn through. I don't go 2. Let's get this here. And this procedure is one of the best surgical procedures we have. It makes everything works very nicely, and they usually have good results. It's rare to have really problems with this technique, and it really works nicely. This is called a mattress suture. We go back and forth to turn the skin edges up so it fits very nicely in there. Let's see, let's get this here. Yeah. I'm going to put one more suture, then we'll be through. Let's see if I can slip one right here. Yeah. Usually takes about 10 days for this wound to heal, and it pretty much releases the ligament and makes them have relief of their symptoms, and she won't be waking up at night with her hands falling asleep anymore. And it works very well, and we'll put a little ace bandage and some dressing on that, and that's it.
Dr. Powell, it was very interesting to see you work again. There's no doubt about it, you're a master. at your trade, and we are so fortunate to have you and the other orthopedic surgeons here at the Summit Healthplex, and so fortunate to have you in Coweta County. And it was just amazing to see the procedure done on the hand today. Tell us, if you will, give us let us go into the classroom of orthopedic surgeons, because I know carpal tunnel syndrome is such a common ailment among so many people. And before you do that, let me ask you this. What causes what are some of the causes of carpal tunnel syndrome, and can you share with us ways that we can prevent having carpal tunnel syndrome?
Well, carpal tunnel syndrome is an entity where the median nerve is irritated, where there's a ligament called the transverse carpal ligament that actually where the nerve runs under in the hand, and this is just sort of showing that. But what causes carpal tunnel is usually overuse injuries, and it's using your hand a lot, computer work. A lot of the children, when they're playing these Nintendos and things like that, I think down the road probably do cause trouble. And what happens in carpal tunnel is it's just basically the main chief complaint when a patient comes in complaining of hand pain is they're complaining of pain at night. They have numbness in their finger. They say they wake up with a hand sound asleep and they have to shake it and that type thing. So what we do to prevent it is we usually start trying initially is the positioning. When you're at work, you need to have your stool positioned where your hands are in an optimum position, where you're not putting pressure on that nerve and causing an inflammatory process to occur. And what we do is, for prevention, when I see them initially in the office, some people like to try cortisone injections, but most of the literature has shown that when you inject them with cortisone, later on they're going to be back in the operating room with you. It just doesn't work. So a lot of times what we do is we send them to physical therapy for stretching programs, trying to free up this space here where the ligament runs across these two bones, the hook of the hamate and the trapezium here. The ligament runs right here, and the nerve slides right under there. So we're doing things to try to loosen that area up so there's more room for the nerve and the tendons. See, what happens is you have the ligament sitting here and the nerve runs under that ligament with 9 tendons. So if those tendons, with using your hand a lot, get inflamed and get inflammatory tissue on them, which I'll explain to you in the operating room, it then of course gets what gets the pressure, the nerve. And that's where the numbness comes. They start getting these burning type feelings out in their fingers. So what we do with the surgery is we make a little small incision, which I did in there, and we release this ligament. And we release it the whole length so the nerve will have plenty of room. And after the release, usually then we repair the skin, and normally they get total relief, and a lot of times it takes a while for them to get the feeling back in the fingers, but the pain at night totally is relieved right away.
Is that immediately?
That's immediately.
The pain is actually on the patient today, so we'll go
tonight,
home, and then tonight her pain will
She should not have the numbness and tingling that she normally has at night pain. But if the nerve has been damaged from all that pressure, the nerve grows about 1 inch a month. It takes about a month for the nerve to start getting its metabolic mechanisms in for it to start growing back. But the nerve grows 1 inch a month, so it takes a while for the feeling to come all the way back in the fingers. And we have some so severe that the nerve has been damaged so much they never get all the feeling back.
How do you treat that when there's extensive nerve damage? Is there anything
sometimes
that you do?
If the nerve has got a lot of inflammatory tissue around it, we do something called neurolysis, where we lyse the adhesions and the scar tissue around the nerve so the nerve will have more room to breathe. But that's rare. Most of the time all you do is release the ligament, and that usually takes care of that problem.
You mentioned video games in children. I know a lot of children. My grandson loves to play video games. So how do you, if you play video games, are there exercises or things that you can do as you stop the process of the video games that can keep you from having carpal tunnel syndrome?
Absolutely, and it's like, in a pianist and a lot of these, in the professional musicians, we see a lot of this, because what they do is that, it's like, a professional musician, and just like a child that's playing the Nintendo games, they can get these inflammatory processes, and like any athlete, you've got to do your stretches. So what we like to do is have them do some stretches of their wrist to work. It's called dorsiflexion, stretch the wrist out.
Like
and then
this,
also the
like
fingers,
this.
yes, to pull everything out, and then also work on some flexion motion too. And we basically just like them to take their arms through full ranges of motion thing, but the big thing is stretching the wrist to stretch that ligament complex out down here at the base of the hand where the transverse carpal ligament runs. And of course, if you start having symptoms or get tired, you need to rest and take it easy and not just continue with the activity you're doing.
Now, one of the things that I enjoy doing, I come over the wire early in the morning, and I've been meeting your brother Frank, and your brother Joe came one time, and we've been looking for you. We ride the bike about 5:30 in the morning, and is there danger if we hold the handlebars too tight? Is there danger that we could have something such as carpal tunnel syndrome? So we need to move our
hands around, the grip strength. You can rotate your hand around so it's not putting as much pressure over this area where the carpal tunnel runs.
Right. So there are ways that we can keep this from
absolutely, and it helps a lot doing that.
From
and also the size of the grip and the size of the handlebar too. Too thick or too thin. Also, that's very helpful too.
Many patients come to the surgery center for this type of procedure. Tell us a little bit, how long does it take for the procedure?
The surgical procedure, there's actually been 2 procedures out there. We've always, when we started doing this procedure, when I started doing it 25 years ago, we used to make an incision from here to here, which I mentioned in the operating room. But what happened was they came out, we're using arthroscopes now to work on the looking knees and shoulders and wrists and pretty much every
But you do not do this surgery arthroscopically.
Well, some people are doing it arthroscopically, where they're making little incisions here and releasing the ligament. But the problem is they've had some injuries to the nerves when they do this, and I don't feel like you can get a view that you really need to see. So what it's made me do, and a lot of other, we call them mini incision carpal tunnels, we've really reduced our incision down to this versus this, and we do most of the work up under the skin. And if you look at the long-term follow-up of these studies, occasionally you get a little pillow pain here from the incision, but it's about 6 to 8 weeks, even doing them arthroscopically versus open, they're basically the same results, and they've done very well. So that's why we feel here, we've looked at the arthroscopic technique. I've actually done some, but I just feel like this is a better procedure. I can directly look at the nerve. I can look at the little branch called the motor branch that I was talking about that comes off the nerve to supply this muscle here, because that nerve can get cut sometimes if you don't look at that very nice, because it sort of comes up at you and then runs right into that muscle. So I like to look at that directly. Then I just feel like I can look at the nerve and see exactly how much I've released and palpate it, so I feel better. That's why I do them open.
Right. Well, you did an excellent job today. And Dr. Powell, I'm so impressed by the diversity of surgeries that's done in the Surge Center by Georgia Bone and Joint. You do different types of surgery. In the days ahead, do you have some future plans? As I know you do not do total joints here. Do you ever foresee a day when you would be doing total joints in an outpatient setting?
That is happening some in the country now already, and I see it coming here. I just think with the right patient in good health, I think we can do that if you have a couple of days, a couple of nights to stay over. The problem is with the CON laws in the hospital, you can't, it's difficult to do them because they have to, they require, like Medicare requires them to be in the hospital 3 or 4 days. But I think hopefully some of the laws will change with time, and I think there are procedures we can do that are going to be outpatient procedures that we do an inpatient then. That's where a lot of this started, was inpatient surgical procedures that have moved to outpatient. I think that's going to happen more and more over the years.
I know I've had some conversation with our Dr. Chad Kessler, who really does a great job with back surgery. I think that's really his specialty, and he's even anticipating doing some back surgery here in the surgery center. Is that being done now?
We're not
in
doing
surgery
that
centers,
yes,
other surgery centers?
I think we'll probably start doing some discectomies.
You don't have to do a CON to do that type of thing, though, as long as the surgery center has the CON and it's
and the fact that the patients, you feel that it's safe for the patient, they can go home without any, at home where there should not be any problems or complications.
Well, that is great. Now, let me one other question related to the surgery that you performed today. Will this patient need any type of physical therapy? Will she go to
occasionally we'll send
them
to hand therapy so they can just take their fingers to range of motion, make sure they get all their motion back, but normally not. Occasionally we'll work with this little scar they have there, but not that often.
Dr. Powell, I'm asked this question from time to time. If someone is having pain in their arms, like the symptoms that you shared earlier, can they make a call here to Georgia Bone and Joint and be seen if their insurance permits them to, or do they must they have a referral from a physician to come to Georgia Bone?
It depends on the insurance they have.
Totally on the
insurance. We try to see them within a week when they call. So, but it depends. Some insurance, like HMOs, I think require them to have a gatekeeper where the physician sees them first, or the internist, the family practitioner, and then refer them into the orthopedic surgeon or other specialties.
Well, Dr. Powell, we know that you are a very busy man, and among all the many things that you do, primarily you are a very gifted surgeon. And on behalf of our community, thank you for building such a great team at Georgia Bone and Joint, such a great team here at the Summit. And I'm one of those guys that's very positive about the Summit Healthplex. I believe our future here is just absolutely unlimited, and I know you join me in expressing gratitude to the community for the tremendous support that they give. Most of the time our parking lot is full, our waiting room is full, and people come here because they know that they're going to get the finest professional care, but it's also going to be combined with a real compassion for people. We're in the people business.
Absolutely.
And so on behalf of our community, thank you. I thank all the other orthopedic surgeons. Thank Russ Foley and all of the other individuals who make this the great place that it is. And we wish you the very best in the days ahead. Thank you for joining us today on The View from the Summit. If you have suggestions for programs, please let us know. Just call me. My telephone number is 770-301-9444. And I trust that you'll have a great day today. And remember, you control your healthcare destiny.